Okay, well, thank you for inviting me and giving me this opportunity to talk about my work. So I'm going to talk today about the population level cascade of care for hepatitis C in BC. This is the outline for today, so I'll start giving you some background about the epidemiology of hepatitis C. Then I'll introduce you to the BC hepatitis testers cohort. Then I'll proceed to show you some results on the cascade of care, stratified by urban and rural areas, and also by some deprivation indices. And then we'll wrap up, and there'll be time for questions. Okay, so as you might all know, hepatitis C is a major global public health issue. In Canada, it's estimated that about 1.5% of Canadians live with this disease, and about 1% in BC. And this graph that you see in this slide shows the trends of hepatitis C in Canada and BC. So if you look at the gray line, that's the number of new cases per year in BC, expressed as numbers per 100,000 people in BC. And then the black line is the same trend for Canada. So this plot shows from 1992, that's when the test became available, to 2015. And you can see that both in BC and in Canada, there has been a trend for a decrease in the number of cases that have been reported every year. And at the end, and in the recent years, we see a plateau, and this is because there's been an increase in testing. So we are detecting more cases. You can see a spike pretty obvious in 1996. And this is because people who had received a blood transfusion between 1992, before the testing was available, were recalled and they were tested, and that explained that peak. The blue line, these are acute cases. This means that these are people for whom we have a negative result in our records, and then we have a positive result within 24 months, sorry. So we know those people have become infected during that time window, that time period. So we call them seroconverters. And you can see a similar trend, a similar decrease over time. So in 2015, there were only 50 seroconverters in BC. There are two main infection groups. One is the new infection, so the seroconverters that I was just talking about, people that we know that have become infected recently, as opposed to prevalent infections. So those are people that we believe they have been infected in the past, so they are suffering from chronic hepatitis C. And these two groups are very different. The new infection group are younger people, and they are more likely to engage in risky behaviors. So at 73% of them, we know are using drugs, and 35% we know that have mental illnesses, and then 10% they have HIV co-infections, as opposed to the prevalent infection group that are older people, and they have way lower rate of drug use and fewer co-infections and comorbidities. So the acute infection group, the new infection group, require integrated care and support to treat all those occurrent conditions. Whereas the prevalent infection group, who is an older group, needs some treatment to make sure that to prevent progressive liver disease. So two different groups with different needs. So the BC hepatitis testers cohort is the data source that I have used to create the cascade of care plots that you'll see shortly. So this cohort includes cases of hepatitis C based on laboratory data. also positive testers for HIV, and also reported cases of hepatitis C, hepatitis B, active tuberculosis, and HIV. So all those cases have been linked to their healthcare data, their administrative data sets, which include prescription drug data, hospitalization data, medical visits, cancer data, and also death. And that allows us to get a pretty good picture of that cohort and follow them. And we can then study exposures that increase the risk of hepatitis C and also the outcomes such as mortality, hepatocellular carcinoma, decompensated cirrhosis. We can do cost analysis, and we can also have, we can also study other covariates such as socioeconomic status or other comorbidities such as diabetes or mental illness. So it put us in a very good position to study this disease in detail. And so the cohort includes data since 1992 until this data I'm going to show you now until 2012, but we are refreshing the data set, so we will soon have data up to 2015. So using this data set, we create this cascade of care plots that give us an idea of how well people progress in the healthcare system, how good of a job we are doing in providing hepatitis C patients with the care they need and the treatments that they need. So if you look at the second column here, these are the total number of cases in our cohort. Total number of positive cases that were diagnosed between 1992 and 2012. And these all includes patients that were still alive in 2012. So we had about 55,000 people that were positive during this period in our cohort. But we know that about 25% of the cases go undiagnosed. So when we add that 25% to that 55,000 people, then we get a total of 73,000 positive cases of hepatitis C in that period. Then how many of the people that are diagnosed go and have a PCR test to see whether the virus is still active in their bodies? So to have what we call an RNA test to detect the RNA of the virus in the body. So it's about 74%. So 74% of the people who are diagnosed then proceed to have the RNA test. Then we know about 25% of people who get infected with the hepatitis C virus are likely to clear spontaneously without treatment, and that's what we saw. Of those 40,000 people that got RNA tested, about almost 10,000 cleared spontaneously. So that was about 23% of people that cleared without any treatment. Of those people that were RNA positive, so the virus was still detected as active in their body, about 85% proceeded to get genotype, to know what type of virus they have, which is necessary to provide treatment. And then of the people who were genotype, only 33% initiated treatment. So this is the big gap in the cascade of care. So until now, we've seen a pretty smooth progress throughout the cascade of care, but the big gap is in treatment, like who is starting treatment. And we can see that there is some sort of barrier here. So we should expect a higher percentage, but only 33% of the people are starting treatment. This is still, because this is data up to 2012, this is still based on interferon-based treatment. So we expect that percentage to go up once the new treatments, interferon-free treatments, are available. And we'll know this shortly with the new data refresh. And then of those people that initiated treatment, 61% cure, meaning that after the treatment, when a PCR was performed again, the virus was no longer detected. So this is the overall cascade of care in BC. So now what happens when we stratify this cascade of care into urban and rural? I have to say we define urban and rural based on population size. So the Ministry of Health published a list of communities that are considered rural or remote in 2015, and that's what we used to decide whether a patient was living in a rural or urban area. So this is the same cascade of care for urban areas. And you can see the same kind of progress throughout the cascade of care. So 75% of people who were diagnosed proceeded to have an RNA test, and about 23–25% cleared spontaneously. Those that were positive, about 85% had the genotype assessed, and then only 34% of those actually started treatment. So the same sort of gap, and 60% cleared after treatment. When we check what happened among those people who live in rural areas, we don't see much of a difference. Again, the gap is in treatment initiation, and for urban areas it was 34%. For rural areas is about 31%, so not much of a difference. So you can see here it's very small, but just so that you can compare the shape of the plot, it's very, very similar. Then just to get a better picture, I also decided to stratify the data into the deprivation indices, so the material deprivation indices and the social deprivation indices. The material deprivation indices is based on employment rate, income, and education rate of the area where the person lives. And the social deprivation index that I'll show shortly is based on social relationships within the community. So basically on percentage of people living alone, single parents, and people separated, widowed, or divorced. So same type of plot for the most privileged people. These are people that are among the 20% more privileged people in BC based on the material index. And we can see the same sort of progress throughout the cascade of care. The big gap is in treatment initiation. So only 34% of the people that get genotyped actually initiate treatment, which is about 13% of the total number of cases of hepatitis C in the period. So when we check the most deprived, those that are among the 20% most deprived people in BC based on material deprivation, we see not too big of a difference. Again, the big gap is in treatment initiation. So it went from 34% to 30% between the most privileged people and the the most deprived patients. So as you can see again here, the numbers are small, so that, but you can still see the shape, very similar progress throughout the cascade of care. Now, what happens when we look at social deprivation? So this is the same plot for the people who are among the 20% most privileged people in BC in terms of social relationships. And we can see that in this case, the treatment initiation is a little bit higher, is still the big gap in the cascade of care, but it's 42% of people who were genotyped initiated treatment. Now we compare this with the patients, the cases who are among the 20% most deprived, socially deprived people in BC. We can see a bit of a difference. Like again, the gap is between genotyping and treatment initiation, but now only 27% of people who were genotyped actually initiated treatment. So it goes from 42% in the case of most socially privileged cases to 27% among those that are considered less privileged or most deprived, socially speaking. So just as a wrap up, there are two major infection groups: new infections, which have higher drug use, alcohol use, mental illnesses, and co-infections, and they require integrated care and support for current conditions. And chronic infections, this group has lower drug use and comorbid conditions, but they are older in age, and they require treatment to prevent end-stage liver disease and premature mortality. So the big gap in the cascade of care is low treatment rates, and we expect those rates to increase with new treatments. Not major difference in the cascade of care between urban and rural remote areas, but we've seen that social deprived cases are less likely to receive treatment. And now I'll entertain any question that the audience might have.
Okay, thank you very, very much, Nuria. I have to change this so that you can see us here. Just a moment.
Yes, I can see you all in the corner, actually.
Okay.
I'm seeing you, yeah.
Okay, view options. Original.
I can see you, Cheryl.
Yes, but we're going to come back to, we're not going to share the screen the same way with you anymore.
Oh, okay.
Just a moment. Okay, there we go. Oh, just a moment.
Oops. Okay, yeah, something changed in my computer as well.
Oh, back to meeting.
Yeah, but I can still see you, yeah.
Okay. Sorry. Back to meeting. Okay, and then, oh dear. Sorry, everybody. Just give me a moment here.
Oh, I think you are sharing with me now. That's what I'm seeing, yeah.
Yes, there's a way of doing this, which I did before. Okay, here we go. Okay, this is still not right. Sorry, everybody. Well, we may just have to be content with this. Okay. I think, Nuria, I think that the people here are pretty shocked that you're saying that there's not a significant difference. But actually, at the end, I believe the number of people getting successfully treated is approximately in the north, or sorry, in the rural parts of the province is 6%, while the percent being successfully treated in the urban areas is 8%. And
yes,
that is actually fairly significant, but it's not as significant as most of us had envisioned. You're saying that it has more to do with social and economic features of the population than with where they live. And we are probably going to have some questions from people who want to know a lot more about how you determine what is urban and what is rural, how you understand that, and what procedures were used. So I'm going to open it up to people. If you have a question, I'm going to ask you to come up here so that Nuria can see you. And if you don't mind, please identify yourself. Okay? So let's have some questions.
Hello, so thank you for your presentation. I was actually a bit shocked that there wasn't much more of a disparity, but could there be some fluctuation with regards to the amount of testing that's taking place in rural and remote communities? So the identification of people in those areas, because what we've seen in northern BC And we've seen this through the Stop HIV pilot project, and then also how that's being laid out regionally, that we're not seeing as much testing happening in those areas. So could that be a qualifier with this also?
Yes, absolutely, because the cascade of care, as I presented it, starts with people who have been diagnosed, right?
Mhm.
So we are aware that there could be differences in diagnosis rate between urban and rural. As you were saying, it's possible that there is less screening. So if there is less screening, then there are more people that go underdiagnosed, and then those people have not been included in this data, right? So this data is, we follow people, but in order to follow people, we need to diagnose them first. So I totally agree that that could be an issue.
Okay, thank you.
Yes, thank you.
Nuria, I'm waiting for somebody else, but until then, how actually did you divide between rural and urban population?
Yes. So we know every case that is included in our cohort, we have a postal code for that person, so we know where that person lives. And as I said, we tried different methods, but then there weren't that many differences among different methods, and we decided the one that was cleaner was this was to divide people into urban and rural residency based on the community where they were living and whether that community had been classified as urban or rural based on population. So we collapsed like actually I have here the table. I think I brought it with me, maybe not. I don't think I have it with me right now, but basically it was on population size. So there was a threshold, and can't tell you the exact number right now, but I thought I had printed out the table, but it's probably sitting on my desk. But it was a very simple way to do it. Like, you know, starting up communities that have a population over a certain number are considered urban, and those that have a population below a certain number are considered rural.
Okay, that's a really, really important thing to people here. If we could get that, could you give it to us in about 10 minutes?
Sure, I can actually, I can look for it. Actually, I can now I'm not sharing, like I think now I'm seeing your screen, but otherwise I can go into my computer and let you know right away.
Okay.
But I see your desktop right now, not mine, so. But I can definitely provide that with that number easily.
Okay, that would be great. That would be great. But before you do that, is there any, there's a couple more questions, okay?
Yes.
Hi, it's Laurel from HepCBC. I'm sort of stuck on in your graphs where you talked about people who have been diagnosed but not accessing treatment. Have you taken into account the barriers to treatment that we have had to hurdle over before 2012?
Yeah, well, this is something that I'm gonna explore further. This has been, I'm relatively new to the hepatitis C group here at CDC, so this is my sort of my first project. But definitely now it's a matter of exploring, okay, what's stopping people from treatment, and we know certain things such as we know people with that use drugs are less likely to get liver care, to get engaged in liver care and start treatment, and definitely other comorbidities such as being positive for hepatitis B and HIV. Also, people that have comorbidities seem to have more problems starting treatment. So we know a little bit about those factors, but yes, we need to explore further and see also now what happens with the new treatments. The new treatments have less side effects, and they are shorter, and they are more efficient, more effective. So we are expecting that number to go up. So that's something that we are going to be able to test very soon. But yeah, definitely we need to figure out what those barriers are in order to overcome them. That's the whole purpose of the cascade of care, to identify the gap and then identify the factors that are influencing that gap, and then try to do something about it. Try to inform so that we can do something about it.
Yeah, I was thinking about having to have an F2 score before we are even eligible for treatment. But I'm
Yes,
that is changing.
That's changing. That's going to change in, I think it's 2000. That's how it is now for new treatments. But the starting, let me see, I think it's 2018. That's going to change. So it's going to be covered for everybody. But again, this data is based on the old treatment, interferon-free treatment. So all the data you've seen, no one was receiving the new treatment yet. So definitely we expect a change once new treatments are available.
Okay, thank you.
Hello.
Hello.
Oh, sorry. I see somebody else has just sat down. I also have some questions, but I'll wait till he's gone through. Sorry.
Hi there. It's Greg with 250 News. I just want to get a comment from you. What stands out the most to you in your research?
Well, to me, is this gap between genotyping and treatment. This is what stands out more in this cascade of care, for sure.
Was that a surprise to you?
Well, it's a surprise for me because I'm new, so I didn't know much about cascade of care. So for hepatitis C, it's surprising, and it's where there is an opportunity to improve things. But I guess considering the complexity of this disease and the side effects of treatments and how long they were, the old ones, maybe it's not as surprising.
I was a little surprised there wasn't a bigger disparity between the lower mainland and the north. Did that surprise you?
Yes, a little bit. Yeah, but it's at the same time is reassuring that people who live in the urban areas are managing to get care at the same rate as people who live in the urban areas, as well, as long as they are diagnosed as we talked about before. As long as they are diagnosed, it looks like they are able to access the same resources at the same rate.
Thank you.
Hi, my name's Jen. I'm a pharmacist, and I agree that I expect the cascade to change a lot based on the new treatments being more effective and more accessible. But can you talk a little bit more about the social disparity and what that was that based on individuals, or just like I didn't quite understand whether it was based on the community they lived in or whether it was
yes.
based on individual, and how we can help that factor.
Yeah. No, this data is not at the individual level. This is based on what's called the Quebec Index. So the way it's done, they divide the geographic area in very small areas of 400 to 700 people, and then they calculate they calculate rates such as in this case for the social deprivation, it was percentage of people living in that area that are living alone, percentage of people that are divorced, separated, or widowed, and percentage of people, what was the other, living alone, and single parents. So then these small areas, dissemination areas, are classified. And then they are divided into quintiles, which is 20% of the population. So this is how it's done. There is no, right now, this is the best guess. We don't have individual data. So this is how it's calculated. Yeah, so there is a little bit of noise there, of course, but it's been validated and it's a good approximation
Thank you.
for now.
Cheryl, it's Alexandra. If nobody there has a question, I have a couple.
Yes,
Can you hear me?
yes, introduce yourself.
Hello, everybody. It's Alexandra King joining you from Vancouver, Coast Salish territory. I'm a physician and researcher in the area of hepatitis C. Hi, Dr.
Hi.
Thank you. This was a really lovely presentation and very lovely work. I have a question, first of all, around the determination of rurality. So you were using something provided by Health Canada, and this would be then, I assume it's a dichotomous variable where if there is a certain size, then it's considered urban versus a smaller size community is rural remote. Is that correct?
Yes, I mean they give you more categories like a small urban, large urban, and then rural, remote. There were different categories, but we collapsed because otherwise we ran into sample size problems. So this is how we did it.
Understandable. I'm very curious as to some other measures of rurality, such as, you know, proximity to a tertiary center or number of doctors in a community or things along those lines.
Yes.
Because I think that may impact who gets into care and who doesn't. And equally, if you were to be looking at, let's say, downtown East Side versus even the rest of the province, what sort of numbers you might be coming up with?
Yes. No, definitely this is like it's an oversimplification of things, but we thought about different methods, and in the past they were compared. I didn't use all the methods that we were compared, but we compared them, and we were getting similar results. I do agree that within, let's say, of course, Vancouver, it's clearly urban, and not all the areas are the same. As you said, downtown East Side is very different from other areas that are wealthier. But I'm not sure. I mean, somebody who lives in terms of access, somebody who lives in downtown East Side, it still has proximity to hospitals and can access to healthcare. In terms of situation, geographical situation, when I see downtown East Side, is more, the barriers are different, right? It's more like social deprivation or even material deprivation. Those are real barriers there, but I'm not sure in terms of geography, right? That they have a barrier there. So it depends on how you define rural and urban, of course. But we thought that this was simple way to show, okay, in terms of actual geographical barrier to access to a health provider. We thought that was like a good approximation, and we tried different ones, like looking more into postal codes, and also I think at some point my team also used number of health providers in a region, and they didn't find huge difference in the different methods. So we just decided for now to go ahead and use this one. Of course, I'm open to revisiting any of those other methods, but for now we thought that was a good approximation to answer our question that was more about geography.
I see. Okay, well, that seems reasonable, but it certainly would be interesting to be perhaps looking at the data in different ways, particularly as we start getting more numbers with the new DAAs, right?
Yes, yes.
Okay.
And now we are going to have more numbers, and we are going to have, the new treatments I think are going to change things. So that's definitely in our next short-term plans to explore data in different ways.
Perfect. Okay, now you had a slide where you were talking about the twin epidemics.
Yes.
And you mentioned about mental illness, and I'm just wondering how the determination of mental illness was made. As a physician working in more rural areas, I know that there are a lot of people who choose not to be on any prescribed medications, maybe doing various things in their own lives to be successful with mental illness. And
Yeah.
you know, and it's almost impossible in some communities to be getting a psych evaluation or something. So I'm just wondering how that was determined.
Mental health was determined based on codes, MSP and that code. So definitely it's our best estimation. I mean, this is all based on administrative data, right? So that's why, I mean, we have over 1 million people in the cohort. So it's all based in administrative data. And most of the time is an estimated guess, and we know we are underestimating certain issues. So mental health was based on codes. So if they had when an MSP code or a DAT code that indicated mental health, that person was considered to have a mental health issue. But yeah, you are right that mental health goes underdiagnosed.
Yes.
So
Okay.
we are definitely underdiagnosing them.
And I'm just wondering if the rates, though, of undiagnosis would be similar in urban versus rural. You know what I mean? So
Yes.
yeah. So I guess
Yes.
that's one of my questions. Another question that I find really interesting is the computation of estimated prevalence. So taking the number that we know are antibody positive and then adjusting by an additional 25. That makes sense. But I'm just wondering if, as we are moving forward and actually having treatment, so people have more motivation perhaps to be screened, if you're seeing a different propensity to screening in urban versus rural, and therefore what the implications are for the estimated prevalence.
Yeah, I totally agree that probably we have just applied this 25% to urban and rural, and as we were talking about before, it's probably not the same. This 25% comes from some mathematical modeling that was conducted by some other groups at the Canadian level.
Yeah.
So it's just again an estimation, and we think it's actually probably lower in BC. The screening rate in BC is higher than in the rest of Canada. So I think at this point we can say that maybe that 25% is too high, and it should be a little bit lower for BC, and it'll continue to get lower as testing increases. Testing has increased in the last couple of years also because some other programs such as Stop HIV. So seeing that increasing trend, probably that 25% will have to be adjusted. And I do agree that it's probably not the same for urban and rural, but it's also hard to estimate how much you are missing, right? Like if you don't know.
Yes.
You don't know how many people are undiagnosed, and it's a very complex question because you don't know. So.
And of course, there could be meaning in missingness. So what we don't know, becomes even harder.
Yeah.
Okay.
Of course, yeah. Like even in the cohort, we know that we are underrepresenting certain people as well. Like let's say homeless people. Sometimes we cannot link them to the health data because they might not have a PHN, or we are missing lots of IDs for that particular group of people. So there are lots of limitations of working with administrative data sets. There are certain biases, but on the other hand, it allows us to have a very powerful data set that can give us a very good big picture of a problem. But we need to be aware of those limitations when we draw conclusions.
Yes, and of course, I think it should be emphasized that the Testra's cohort is one of the best that exists. So
yes, but again, it's a cohort. It's not a population level data set, right? It's a cohort. We are selecting those people that are tested for hepatitis C and hepatitis C and HIV, and then we select those that are positive to try to follow them and see where there is a gap in healthcare. So it's very different from a real population sample. But again, as long as we are aware of our limitations, I think it's a very powerful data set that's going to allow us to to explore many things, such as how much better new treatments are in terms of clearance, but also in terms of people starting treatment and sticking to the treatment and that sort of things. So we are quite excited to actually work with a new refresh that will include people that are already taking the new treatment.
Right. Okay. So I just have one comment and then a final question. I don't want to monopolize any more time, so my apologies. But I find it quite fascinating that when you're looking at rural, and so I just scribbled down numbers as you were talking, so maybe I got them wrong, but urban versus rural, 8% versus 6 in terms of cured. Material deprivation, most versus least, 8 versus 6. And then social deprivation, most versus least, you're looking at 10 versus 6, right? So what that's saying to me is that the rural is...
Yeah, you're talking about people with where like that clear after treatment, right? Yes.
Yeah, cured. Yeah. And, you know, and you can go back up because the numbers are sort of consistent as you're going across those different dimensions in that, you know, if you're urban, materially well off or socially well off, then you have the best rates. And if you are rural, materially deprived or socially deprived, you have the worst rates.
Yeah.
And perhaps we had other ways of looking at rurality. You may even find a bigger signal depending on how you did the analysis. And the numbers, by the time you get out to most cured, I assume that we don't actually have statistical significance. Is that correct?
Well, this is just a big descriptive picture because, of course, as you were saying, I think you were going that way, that like it's not all independent, right? There are lots of confounders. People that are in rural areas, on the top of being in rural areas, might have this, and this characteristics.
Right. Yeah.
As compared to being in an urban area. So this is like an oversimplification of the problem. And now with the new data set, we are just going to explore all those interactions and learn more why we are seeing differences in certain areas and in not others, or why there is that gap in treatment, if we still see the gap with the new treatments. So this is just a descriptive plot, just to see the whole picture in terms of numbers. Like how many people should be treated and actually are not. So just to get a little bit of an idea of the magnitude of the problem and where the main problem is. Now we need to do more detailed analysis to explore further those problems.
Now, I happen to be the only Indigenous physician in Canada that I know of who's treating Hep C at this point in time. And Indigenous status is, I think, very important or a critical lens.
Yes.
I'm wondering when we're going to be getting the Indigenous analysis. And I do realize the complication in that question. So, yes, but you know, with the recent Truth and Reconciliation calls to action, which is saying we need regular reporting and ensuring that there's a closing of the gap. If we don't even know where we're starting from, it becomes very difficult to be looking forward, right?
Yes, no, definitely things like ethnicity and Aboriginal status are very important. We do not have data yet. We are working on getting ethnicity data, so hopefully in the future we'll have, because definitely I think this is a very important information that we need to really keep exploring this cascade of care.
And
but right now we don't have it.
Ethnicity, and obviously New Canadians are another major group that are disproportionately affected by hepatitis C. And so that would be of interest. However, I want to make the distinction that Indigenous is a completely different category to ethnicity. And we have a constitutional right that is different from other groups.
No, absolutely, absolutely. But I was just adding that piece of information that we are also missing ethnicity, which plays an important role in here. Yeah.
Okay, thank you so much. I really appreciated your work and your presentation.
Thank you.
I was just wondering if you have any data on people that have cured their Hep C on their own, and if you are doing research about that. And if somebody gets reinfected, are they able to start treatment, or would you rather wait and see if they cure it again? It's just something that
So yeah, I showed numbers of people who cleared spontaneously. So those are we believe it's around 20. In our case, it was 23%, but the literature says about 25% of the people who get infected clear spontaneously. Of course, those people, if they can get infected again. And we are, not myself particularly, but our team are doing a lot of research on reinfection rates. And those things happen. If they continue to be affected by the same risk factors, they could get reinfected. So yeah, treatment can be provided at any time when a person is diagnosed positive. Even if they clear, they get reinfected again, then they should be treated. They could clear again, but I don't think it's the point waiting to see whether it clears. Yeah.
So does somebody have to wait till they're like sick to start treatment, or are you just letting whoever wants the treatment to start?
With the new treatments right now, they are provided to people that have some advanced liver damage, but starting in 2018, those new treatments, which are much better, will be covered for everybody.
Cool.
Yeah.
Hi, I'm Janet. I'm a nurse. My question is similar to Christina's, that I'm wondering if you know of any research that has happened or is happening that looks at the 25% of people that clear it. What factors make them more likely to clear it versus the other 75% who aren't able to clear it spontaneously?
Yeah.
It makes that 25% a bit more elite.
Yeah. There is definitely research on that. I do not have an answer right now, but I can send some references after I can look for some references and send you your way. I haven't done any research on that myself, so I'm not sure whether there is any factor that explains that, why some people clear and some others don't. I can't answer right now.
Okay.
Yeah.
Anyone else? I think that's all the questions we have
Okay.
for today. But we do need you to look up the threshold for
Yes.
urban versus rural.
Mm-hmm.
And I'd also like to point out again to everyone that your data only goes up to what, 2012?
Yes, what I showed today, yes.
Which is before the new direct acting antivirals, which
Yes.
are now available or being used. So a very different treatment at the time of this point in time that we're seeing on this presentation. And the other thing I wanted to point out is that you really don't have a population idea of what is being done as far as testing in the rural, remote, and northern areas. So if you don't really know if the rate of testing is comparable to that of urban areas, it's a little bit like comparing apples and oranges. Am I correct?
Yes, I mean, here we are comparing, we are following people who have already been diagnosed. So once they are diagnosed, we don't see differences between urban and rural. Of course, the people we are missing because we are not diagnosing, that we cannot compare. We don't know whether it's the same or not. And it makes sense to think that it's worse in rural areas. But what I'm comparing here, I think it's apples to apples because I'm just comparing people, once they are diagnosed, how well they are progressing throughout the cascade of care. So in that sense, I do believe we are comparing apples to apples. But yes, if we want to compare the whole population and what happens to the whole population, then it's impossible for us because we don't know how many people we are missing in each environment.
Right.
Yeah.
Oh, that's a great explanation. Thank you.
Mhm.
Thank you so much. And
Okay.
now please find that threshold number.
I'll send it to you right away because it's sitting in my table in my computer as well, but I cannot access
Oh,
my right now, but I'll do it from my office and I'll send it to you by email. And then, yeah,
okay.
I'll find some references on a spontaneous clearance as well.
Okay. And could you just, actually, we just need that one number as soon as possible. If you could just phone my, you've got my phone number, right? If you could just phone that number to me.
Yes.
We have to leave at 12 and.
Okay, if you want to, because I don't think you want to record this, if you want to stop recording, I can just run to my office next door and give it to you right away.
We'll keep it on then. Okay.
Okay,
Beautiful. Thanks.
just one sec.
Any other questions?
And so, was it Jeanette question or Janet?
Janet?
Was Janet question to answer a question about the spontaneous grant? Since I've researched on Erica's and the NC educated here. In terms of spontaneous clearance, there is research. I do have some
Okay. Oh, where is Cheryl?
Great.
Oh, you're still recording. Yeah. Okay, so yeah, rural is 20,000 people or less. Yeah.
So how far would you have to be, like from Vancouver, even if you were in a small community, if you were X number of kilometers from Vancouver, you would still be considered urban, right?
If it's a big, yes, if it's a big community and it's far from Vancouver, it's still urban. Yeah. This is not, it is not based on distances. So the classification was rural, small rural, or remote. Remote is a community that goes from 0 to 1,000 people. But again, it's based on population, not on distance.
Great. And maybe at some point you could do a even a rural versus remote Cascade
comparison. Yeah, the only problem is that then once you get into remote, probably the numbers are very, very small.
Right. Okay.
So then you start seeing noise and it's difficult to see whether differences are just based on, are because of a small sample size or they are actual differences. But I mean, there are more geographical analysis that can be done. I mean, again, this is just a simple big picture plot. So the possibilities are endless. And of course, we're going to consider more options. But for now, this is what we've done.
Oh, it's great. We really, really appreciate it. Thank you very much.
Thank you.
Oh, we had one more comment. Oh, okay. Okay, we will be in touch with you later about
okay.
The spontaneous clearance question.
Okay.
Bye-bye.
Okay, thank you so much. Bye.
Stop sharing. Oh, okay, there we go. Stop